We're looking for some room because there are others who want to come in, so if you can move towards the center of your aisle, that will allow some others to come in and join our session. My name is Dr. Dan Ouellette, and I'm from Henry Ford in Detroit, and welcome to a session where we'd like to introduce to you a guideline which will be published within a few weeks on transfusions in the intensive care unit. In 2019 or 2018, Dr. Angel Caz and I got together and we decided we wanted to develop this guideline, and we've been working on it since then. And well, we have been, and it's been a journey that has been very interesting. And we wanted to cover not only red cell transfusions in the ICU, but also other blood products and address some of the common problems that we face every day in the ICU in terms of procedures and things of that sort. We knew when we set up our panel that the one person that we had to have to give us credibility was Dr. Paul Hebert, and Dr. Paul Hebert graciously joined us on our panel, and he's going to be our first speaker today. He's going to give us some opening remarks, and then we'll have several talks, and I hope we have time for questions and a little bit of panel discussion at the end. So thank you very much for coming, and I hope you enjoy this session.
Sorry, thanks, Dan. I just had a few slight difficulties with my slides, so guess what? I'm doing opening remarks without them. So thanks for having me. And I'm just going to give you a few minutes of an opening remark. We're going to have a number of the panelists come up who've been working together, as Dan said, for what, better part of close to 3 years? 3 years. The panelists have been working together for 3 years now and have given some thought, a lot of thought on your behalf to help you decide how best to transfuse blood products in the intensive care unit. So I started on this journey actually in 1993, so a few years longer than Dan suggested. The guidelines program started up. At the time, for those of you around back then, there was a lot of work being done on increasing oxygen transport. And the idea at the time was to increase it so much that you overcame the oxygen debt caused by sepsis and other ischemic injuries. So for those of you who remember that time, we were augmenting oxygen delivery with dobutamine, with fluids, and some people tried with blood. So when I started down this journey, I was doing a whole lot of basic research on blood as an oxygen carrier to increase oxygen delivery to overcome that oxygen debt. When I first presented the trial as part of our Canadian Critical Care Trials Group program in 1993, having worked on it for a few years before, after a 4-hour painful session with my colleagues at the time, they told me I was nuts. They told me it was a great question, but the focus ought to be simply on blood transfusion, not on oxygen debt. And it changed the whole program around, and that was due to my gracious colleagues who told me the truth at the time. 2 years later, we got the grant funded, the trial funded, and it took us about 4 years to get it done. And as you know, it was published in 1999. At the time, when I first submitted it for publication, the New England turned it down. They turned it down because they sent it to a bunch of blood transfusion people who said, "We know this, why are you sending us this manuscript?" And then in the editorial note from the editor at the time, an old hematologist here in Boston, he said, I asked him, there's a little note in the second paragraph said, well, we're kind of interested. You know how they write, I don't know if you've ever gotten those, where you get these refusals of manuscripts, but then there's a little note in it that says, well, maybe. So the maybe was a bit bizarre. I didn't quite understand what he meant, so I called him up. It's always a good thing to think when you want to get something published and you think it's worth it. Called him up and I said, Dr. Schwartz, what happened? I presented this at a major international meeting, Jean-Louis Denis meeting that same year, and it was pretty cool. Everybody wanted to see more of it. And I said, Dr. Schwartz, did you happen to send this to critical care people? And there was a blank silence on the call at the other end. Lo and behold, he had not. He had sent it to blood bankers for review. So he asked me to send it back, which I did, and I fixed up a bunch of stuff and got it in. Since then, it's been cited a few times. And since then, the dramatic part about the whole thing was I was expecting more blood to be better, to be honest, and going into the trial. And at the end, it was exactly the opposite. So much so that when we were doing the review of the data, I asked the statistician if he got the code right. So, and he wrote it, he went through it 3 or 4 times, and sure enough, it was right. So what did we find in that initial trial? Well, to our surprise, it was supposed to be an equivalency or a non-inferiority study. Our reasoning at the time was that if blood transfusions don't change something important, why are you giving more? It's that simple. It's a simple question. You give more, you give less. We had 2 transfusion triggers. The 100 trigger, or 10 for you guys, sorry, was really designed to test the historical 100 threshold, which came from somewhere 40 years before then from a gynecologist who thought it was the right trigger. It was a nice round number, and then everybody made up some science around it. So we tested the historical trigger versus as low as we possibly could get away with. So 70 wasn't anything, 7 wasn't magical. It was just we thought we could get away with something that low. And the literature suggested that, you know, when you looked at the laboratory studies from animal studies, all kinds of them seemed to be okay. And some of my colleagues, especially a few in Toronto, some of you might know John Marshall, he was adamant that blood did a lot more than transport oxygen, and he said, we like to transfuse a lot less where we are. So I said, great. And we had a big debate about how much and how low, so we did, and those were the 2 arms. So the historical precedents, the 10, the 7 was to test the new threshold. The idea was, can we drop the trigger enough to demonstrate a difference between groups? It would be biologically plausible to be of benefit in the 10 or the 7 group. There were 2 kinds of theories supporting both. And what we ended up finding in the end was that the lower threshold, the restrictive one, certainly didn't do better. It was either it did a little bit better, possibly in some of the subgroups, and or it was equivalent. But the best we could hope for was that it was equivalent. And then we had to argue with the editors to finagle all the language. So in the end, we did that study. It seemed to change a lot because in the end, it told people you could get away with a lot less. Now, fast forward, how many years? Since 1999? No, significant number. There have been about 37 odd trials published now. We're just updating the Cochrane review now. They are in a variety of fields, which you'll hear some of which about today, but they range from ICU, perioperative medicine, GI, and in a number of hematologic malignancies, and it goes on and on and on. So there's a large variety of fields, which you'll hear about later today. Overall, what's been demonstrated is that there are a few things. One is we were able to reproduce the results, so it wasn't just our study. And as you guys know, in science, we're supposed to reproduce, and we did. So our initial results came out to be reasonably true. The blood transfusions are not, it's not like transfusing or giving a pill. It's a biological, and it's gotten from donors, and so the preparation of the product changes a lot from country to country, or can. And based on that, it has different biological effects, most of which we care less about. And so over the years, not only have people reproduced our results, but we've investigated the old versus fresh blood story, whether leukoreduction did stuff. So in the end, we've done a whole lot of science around more or less, different subgroups, and what the product does itself, most of which we found doesn't make as much difference as we thought. So, for example, the fresh versus old story, we thought fresh blood would be better. Turns out it might actually be a little worse for all kinds of reasons, which I won't go into today. Leukoreduction seems to make a difference, but not a big one. So we leukoreduce our blood supplies, because when you give a unit of blood, there's a whole bunch of stuff in it that's not red cells. And the white cells matter. They immunomodulate. If you don't take them out quickly enough, they can be biologically active. So could that hurt people or not, especially our neonates or ICU patients? Turns out they do some stuff, they just don't seem to kill people. So it matters, but not that much. So if we go back, I'm just going to stop my opening remarks now, but over the last 25 years, we've done a large number of trials. I've helped a whole lot of them. In ICU, you're going to find out what we propose to do next, so I won't give away the punchline. I would suggest that overall, a restrictive strategy is still the best approach in most patients, but you're about to hear that maybe that caveat should be modified a little bit in a few subgroups. As most of you know, and if you want to hear more about, the MINT trial was just published, and it's got some very compelling findings. It was in the New England Journal, last November, which I'm happy to talk about in the panel after, and one of our colleagues is going to make some notes around it. And there are two trials yet. Well, there's another trial that was just published, maybe less of a concern to you guys, but in acute traumatic brain injury from Alexis Turgeon and colleagues in Quebec City, and that was just published in New England, in July or June. And there will be another two published this year in their neurocritical care arena. So it seems to me we're going from the general, which I think restrictive is generally still what we should do, to some of the specific high-risk subgroups, cardiac being one of them, and then neurocritical care may be another. So we're about to hear not about all of that, but certainly the cardiac, the GI, the sepsis, and everything else which matters to you folks. So I will stop there. My apologies for not having slides, but I can certainly vouch and talk about any of the content regardless. I'm to introduce, I guess, the first next speaker, which is Dr. Dan Ouellette, who has basically co-chaired the panel for the last several years, and as you heard, was its driving force, and he's going to tell us a little bit about what red cell transfusions in cardiac disease, which I just highlighted. So thank you for the chance to give you a few opening thoughts, and I look forward to the discussion of our panelists.
Thank you so much, Paul. Appreciate that a lot. Paul doesn't know that I've been reading his articles for 20 years, and it was a great honor to have him on our panel. So I do have some embedded questions. If you take a picture of this QR code, you can answer my questions. I'm going to talk about cardiac disease. I can put it back up there for you. We're going to talk about it. It's also at the bottom of each question, so you can, if you miss it this time, you'll be able to get it. I'm going to talk about cardiac disease. My talk will be brief. I'm going to talk about the PICO questions that we chose that are related to cardiac disease. For each one, I have a question for you. The questions are all about thresholds that you should use, so I'm just briefing you on what to expect. All of my disclosures here relate to research grants, none of which, from none of which do I receive funding, or personally, my institution does. We're going to study patients with acute MI, cardiac surgery, and people with elevated troponin levels. Those are the three PICO questions we're going to address today. This is our panel. And my first patient presentation on which the question is based is you have a 56-year-old man in your ICU, and he's admitted with chest pain. He has a history of COPD, alcoholism, and diabetes. He's got a ST elevation MI. He has no active bleeding, and you notice 3 hours after he's in your ICU that he has a hemoglobin of 7.5. These questions are all about thresholds, and so the question is, what is the best response in terms of transfusing this patient? You shouldn't give any transfusions because he's not actively bleeding. You should not give transfusions because his hemoglobin is greater than 7. You should give a red cell transfusion because the hemoglobin is less than 8, or you should give a red cell transfusion because the hemoglobin is less than 10. What's your best answer? This is based on the response to this question is based on what you'll see in our guideline, which is going to be published in the next few weeks. And the answer is the last one. So sometimes, Paul, giving blood is a good thing. And should critically ill patients, this is our first PICO question, with acute coronary syndrome be treated with restrictive or permissive red cell transfusion strategy? Our recommendation will be in critically ill patients with acute coronary syndrome, we suggest against a restrictive red cell transfusion therapy. So that's what our guideline will say, and that's probably a change in what some of us have been doing. The thresholds that we looked at for restrictive versus liberal are listed here, and some of this is relevant for the other speakers as well. We're looking at number 3, acute coronary syndrome. The studies that have been done have looked at 7 and 8 as restrictive versus 10, which would be liberal. And in terms of a pooled analysis in the studies that we looked at, these are the relative risks and the absolute risks, and you will see that for all of these outcomes, the relative risks generally cross unity. So at first glance, you say, well, there's no difference between restrictive and liberal. This is the forest plot. You look at the forest plot in the summary block in terms of 30-day mortality, and you say there's no difference between restrictive and liberal. Our decision about this guideline was based on the recent MINT trial, which Paul referred to. And it's important to think about this study. In the MINT trial, they used a restrictive versus liberal strategy, and you can see what the actual hemoglobin levels were in these patients in the MINT trial who had acute coronary syndromes. You can see clearly that the people who were in the restrictive arm got less blood than the people who were in the liberal arm, which is not a surprise. These are the outcomes that you can see from the MINT trial. And what I would suggest to you is if you look at myocardial infarction death in terms of the primary and secondary outcomes, there is a suggestion that the liberal study was better. And what really troubled us when we looked at this data, it didn't trouble us, we thought was important, is that when you looked at cardiac deaths, the secondary outcome, there was a clear benefit for the liberal strategy. And so from that, both the authors of this study and we thought that there was the potential for a risk for harm by following a restrictive strategy in these groups of patients with acute MI. So the point estimates for 30-day mortality, need for revascularization, and cardiac adverse events favored liberal strategies, although were not perhaps significant in terms of not crossing the line of unity. But cardiac deaths were increased in the MINT trials in the restrictive group, and we were concerned that restrictive strategies may actually cause harm. We don't know whether the hemoglobin value of 10 is a threshold effect, or if, as I would suspect, the risk increases progressively below this level. But our guidance to you would be that we think that you should favor a liberal strategy in patients with acute coronary syndromes in your ICU, and think about a hemoglobin level of 10. Second patient, 64-year-old man in the ICU following a CABG. He's got diabetes and hypertension. He's intubated and on the ventilator. He has stable vital signs, but the thoracic surgeons have him on lots of different vasoactive drugs following his surgery. He has no active blood loss. He has a mild AKI. He has no evidence of cardiac ischemia. You can interpret that however you want, but any tests that you do, there's no evidence of active cardiac ischemia. He's got a hemoglobin level of 7.1, which I picked on purpose for this question. So you don't give red cell transfusions because he's not actively bleeding. No red cell transfusions because his hemoglobin's greater than 7. Red cell transfusion should be given because he's less than 7.5, or red cell transfusion should be given because it's less than 10. All depends on what you like for a transfusion threshold. That's what the question is about. I'll give you a few minutes to choose. And our guidance will be no red cell transfusion should be given because he's less than 7.5. This comes from the studies, really, and I'll show you what that's all about. So should critically ill patients undergoing cardiac surgery be treated with a restrictive or permissive strategy? We suggest a restrictive strategy over a permissive strategy. The difference is that the studies that have been done in this area have a different transfusion threshold for restrictive strategies than 7. So if you look at this guidance in post-cardiac surgery, the studies that we've looked at use for restrictive strategy thresholds of 7.5 to 8. So don't feel too bad if you put down 7 as the limit. In the studies that have been done, the relative risk for all of these things crosses, when you compare liberal to restrictive, crosses unity line. And the forest plot shows maybe a slight favor towards permissive therapy, but again, in terms of mortality, not. So we're going to recommend a restrictive strategy. There are 2 trials that I wanted to call out. One is the TRICS study, which looked at 9.5 versus 7.5, and it was a study which ultimately demonstrated, looking at mortality, that restrictive was non-inferior, and the patients who were in the restrictive group received fewer transfusions. And in the second study, this showed that restrictive was not superior to a liberal transfusion strategy. And we also had to take into account not only the mortality rates, but the potential for adverse consequences of transfusions, which you should think about when you're looking at thresholds and making a decision about these patients. Third PICO question, a patient with COPD, history of coronary artery disease. He's in your ICU for an exacerbation of COPD. He's got bad COPD. He has a history of an MI. He had revascularization done 5 years ago. Hasn't had problems since. He's on the typical outpatient regimen for his COPD and his heart disease. You give him bronchodilators, but he needs to be intubated, and he's on the ventilator. And 24 hours after admission, his troponin level is 25% higher than the upper limit of normal. He's sedated, so he's not talking to you. He has no EKG changes from baseline. If you want to throw in an echo that shows stable findings with a good LVEF from prior echoes, you can do that too, but there's no evidence of ischemia. His admission hemoglobin was 9, and then 24 hours later in your ICU is 7.7. So what should you do? Should you give no transfusion because he's not actively bleeding? No transfusion because his hemoglobin is greater than 7? Give it because his hemoglobin is less than 8.5, or give it because his hemoglobin is less than 10? Waiting for the votes to tally, and everybody is mostly right, because we shouldn't give a transfusion because his levels greater than 7. So our recommendation in this group is, in the patient with an isolated elevation of serum troponin without other evidence of cardiac ischemia, we suggest that you should use a restrictive strategy. No data is available on this, on the question of troponin elevation and transfusion without other evidence of ischemia. We all said this is really important. We deal with this every single day, so we need to say something about it. We recognize that there's no universal definition for what an elevated troponin level is because of the variety of tests and the fact that normal values vary. We identified the idea that the troponin is a test value. It's not a diagnosis, and there's lots of conditions that lead to an elevated troponin level. So we say you should use your judgment when you take this into account and you think about these patients. I would refer to Dr. Hebert in his original study where he had patients with cardiovascular disease, albeit not active ischemia, and using a transfusion threshold of 7 seemed to be perfectly good in that group of patients. So, in summary, for acute coronary strategies, use a liberal strategy. It's changed my practice to see the most recent trial. This isn't what I used to do a year ago. It's what I do now. For cardiac surgery, choose a restrictive strategy. The thresholds are a bit different. And for isolated elevated troponin, 7 is good, but use your judgment. Think about your patient and try to put your decision in the context of your patient. Thank you very much. I'd like to welcome Dr. Pendleton to the podium to talk about GI bleeding.
Thank you very much. So as you heard, I'll talk about red blood cell transfusions in the patients with active GI bleed. I'm Katie Pendleton from the University of Minnesota. I have no disclosures. So we'll review the studies informing the CHEST guideline for the red blood cell transfusion in this area. There were only 4 of them, so it'll be short and sweet. And then I'd like to end by comparing our guideline recommendation to the existing society's clinical practice guidelines. Those are mostly from the GI societies. So the PICO question we addressed is whether a restrictive red blood cell or permissive transfusion strategy should be used for patients, adult patients with active GI bleeding. The outcomes of interest in this area were hospital mortality in both upper and lower GI bleeding, short-term mortality specific to upper GI bleeding, one-year mortality, ICU and hospital length of stay specific to upper GI bleeding, need for rescue surgery in either upper or lower GI bleeding, and that was balanced against the adverse effects that we identified, which again included transfusion reaction, significant infection, cardiac, renal, pulmonary complications, and significant clotting. So I'd like to start by just reminding us of the rules of engagement. So again, this will apply to adult critically ill patients. One specific thing I'd like to call your attention to is that none of the studies that we reviewed included patients with hemorrhagic shock or those who are actively exsanguinating from GI bleeding. This was defined variably in the studies, but in broad strokes, these were folks with systolic blood pressure of less than 100, a heart rate of greater than 100, or those requiring transfusion within 2 hours of presentation. You've already heard from my colleagues that the way a restrictive or a liberal strategy is defined varies by the study. Generally speaking, a restrictive strategy is targeted for transfusion below a hemoglobin of 7 or 8, and a permissive strategy was somewhere between a hemoglobin of 8 and 10. And we'll get into the studies. So the first one and largest one is this one from Villanueva et al., published in the New England Journal in 2013. This was a single center study from Spain and included 921 patients with severe acute upper GI bleeding who were randomized to a restrictive or a liberal strategy. The respective hemoglobin goals for this study are shown there. About 50% of these patients, the majority had bleeding from peptic ulcer disease. About a quarter of them had esophageal variceal bleeding. All patients in this study received an EGD within 5 hours of presentation. Their outcomes were 6-week survival, further bleeding episodes, and adverse events. And you can see from the survival curve here that there was a clear benefit to a restrictive transfusion strategy. And the study showed a 45% risk reduction in mortality, with fewer rebleeding events, decreased adverse events in the restrictive group. Notably, the average transfusions in the restrictive group per patient were 1.5 compared to 3.7 in the liberal group, and about half of patients in the restrictive strategy group avoided transfusions altogether. This next study was not actually a true randomized controlled trial, but it was a phase 2 feasibility study that was performed across multiple centers in the UK. It included 936 patients with severe acute upper GI bleeding, randomly assigned to either strategy with the hemoglobin targets there. Again, most patients in this study had bleeding from peptic ulcer disease as their main source. Their outcomes were feasibility. Again, this was a pilot for feasibility study. Transfusion exposure and amount, further bleeding, clotting, number of infections, and mortality. This is a summary of their results. You can see that patients in the restrictive policy group received far fewer transfusions, so only 33% received at least one transfusion compared to 46% in the liberal strategy group. They did not find any significant differences in either all-cause mortality or further bleeding at day 28 or serious adverse events at day 28. Again, this was a feasibility trial, not a true RCT. But this 13% absolute reduction in patients transfused was significant without increase in adverse events. And at their institution, this translated to an estimated savings of 3.3 million pounds in blood alone, which is quite substantial. This is a smaller study published in the Saudi Journal of Gastroenterology. This is again patients with upper GI bleeding comparing a restrictive and a liberal strategy with targets shown there. Their primary outcome was 45 days mortality. And you can see from the graph here that they had no significant differences in in-hospital deaths at follow-up, which was 45 days, and overall mortality, leading them to conclude that a restrictive strategy was non-inferior to a liberal one. This last study that I'm showing is the only one that met our inclusion criteria that handled lower GI bleeding. This was a post-hoc analysis of a UK national comparative audit of lower GI bleed and the use of blood. For their purposes, a liberal transfusion strategy was any transfusion administered for a hemoglobin over 8, and they had no difference in any of their outcomes, which included odds of rebleeding, in-hospital mortality, or their composite outcome for safe at discharge. This is a meta-analysis that we created as part of our guideline looking at one of our main outcomes, which was hospital mortality. Again, this was specific to upper GI bleeding. You can see the 3 studies that I reviewed showed here. This is heavily weighted by the Villanueva study at 50%, as that was the largest with most patients, but you can see here that there is a benefit to a restrictive strategy. So our guideline recommendation will be, in critically ill patients with acute GI bleed, we recommend a restrictive transfusion strategy over a permissive one. This is a strong recommendation from a moderate certainty of evidence. I would again like to remind you that this does not apply to patients with hemodynamic stability, so those presenting in hemorrhagic shock due to acute GI bleeding, because the patient population was excluded from these trials. Our recommendation is consistent with recommendations from other major societies, which also favored a restrictive transfusion strategy. Most of these guidelines stipulate that a hemoglobin level of 7 meets their criteria for restrictive strategy. This may be particularly true in patients with bleeding related to portal hypertension, as a restrictive strategy has been shown to lower portal pressures, reducing the risk of rebleed and improving survival. So in summary, this trust guideline recommends a restrictive transfusion strategy, or as the folks in my GI shop like to say, defend the hemoglobin of 7 in these patients. You may consider transfusing for hemoglobin values higher than 7 in patients presenting in shock. One thing that I should also mention is that like the Villanueva trial, which contributed 50% of the patients, actually excluded patients with cardiac ischemia. So we do say that it would be reasonable to consider a higher transfusion strategy in those with significant coronary artery disease. And our guideline aligns well with existing guidance from other major GI and hepatology societies. And that's what I have.
Thank you, Dr. Pendleton. I'd like to invite my co-chair, Dr. Angel Yataco, to the stand.
Thank you very much, Dan. And it has been really an honor to work on these guidelines for the last 6 years? No, it's just 3. But something happened in between, COVID, and kind of derailed things a little bit. So things were a little bit slower than we initially intended to be. So the question that I'm going to address is if transfusion should be part or not of the sepsis bundle. And full disclosure, I'm going to be kind of a politician on this one because as we review the evidence, we may see that actually the studies that we found actually did not necessarily include transfusion as part of the sepsis bundle, as we know early Ouellette therapy and all the subsequent studies that follow that. So this is the objective, to understand if the red cell transfusion should be considered not part of the sepsis bundle. I have no relevant financial disclosures, and this was the PICO question that we framed at the time. The population would be critically ill patients with septic shock and end-organ hypoperfusion. The intervention would be RBC transfusion in addition to usual care. And in this case, we were defining usual care as what the studies define, so we gave that liberty when we included our studies. The comparison would be usual care alone, meaning usual care that used the accepted thresholds, which are typically around 7, and then the outcomes of interest, I'm going to show you in the next slide, are ICU mortality, 1-year mortality, 30-day mortality, and then the adverse transfusion effects. And when we developed our guideline, we selected critical outcomes, which are the ones highlighted in blue, and then the other outcomes in dark gray are important outcomes but are not critical. And this is important because the critical outcomes are what introduce the signal of the strength of the recommendation. Those are the outcomes that we actually consider in the process of evidence to decision. We identified around 1,500 studies, and part of the work of the panel is to screen those initially by title and abstract, and then finally identify those that are suitable for inclusion in our meta-analysis. And ultimately, 21 studies were included, and of those, 3 met the criteria to be analyzed as part of our guidelines. So the first one is this study that evaluated patients who had hematologic malignancies and septic shock. And the authors evaluated transfusions at a threshold of 9 versus a threshold of 7. It was a single-center study, and again, it's a subpopulation of cancer patients with septic shock. And as you can see here, the separation of hemoglobin levels was very clear. The liberal had cutoffs above 9 and the restrictive less than 9. And at 30 days, there was no mortality difference. As you can see, the Kaplan-Meier started splitting by day 90, but our outcomes did not include 90-day mortality, so we had to go with the short term, which was 30 days, and then 1 year, in which we only had one study. What was interesting is that, and I think this is important, it's going to be key in all the studies that were analyzed for the guideline, is when we choose a liberal strategy, we transfuse a significant higher number of red blood cells. In this case, for example, the liberal strategy, 61% of the patients were transfused versus in the restrictive only 41. So we're talking about 20% of our ICU population with septic shock being transfused or not if we choose one approach over the other. And then the number of units, you can see here that is 300 versus 212. So it's 50% more the number of RBC units. And we know that cyclically we go into shortages of RBCs, and if we're going to use an intervention that is going to produce a significant shortage of resources and significant costs, we need to be sure that it actually is going to change clinical outcomes. And so far, at least on the data that I have shown you, that's not the case. Then this is the TRIS study that was published in 2014 in the New England. Again, a multi-center RCT. This one included ICU patients with septic shock. There was no subpopulation as far as cancer, liver, et cetera. And again, they compare a lower threshold, which was 7, and a higher threshold that was 9. Very nice separation on both groups. And then when we see the Kaplan-Meier, there was no difference in mortality at 30 days, 90 days, or whatnot. Again, these patients were stratified based on the presence of chronic cardiovascular disease, on the severity of illness, or based on age, and there was no change in the signal as far as harm. But again, something we're going to see throughout all these studies is that liberal strategy patients, almost every patient was transfused, almost 100%. In the restrictive approach, 63%. And when we look at the number of units that were used, we're looking here at about 1,500 units spared if we choose a restrictive approach. And it makes sense, right? Because so far we're not seeing a mortality difference. And why use an intervention that is going to make a number potentially look better, but it does not translate into patient-centered outcomes? And lastly, this is a smaller study that was done in Brazil. Look at, again, patients with septic shock, hemoglobin threshold of 7 versus hemoglobin threshold of 9. And this was a smaller study, only had around 40, 50 patients. So they were not powered for mortality. And the outcomes of interest for them were lactate clearance and change in SCVO2. And what we identified was that, yes, patients that were transfused had higher hemoglobins. The SCVO2 did respond to blood transfusion, as did the lactate levels, but the mortality, and it's not in this slide, there was no significant difference. So when we put all of this data into our forest plot, you can see that this is for ICU mortality. There was no difference in ICU mortality. Same for 30-day mortality. It crosses the line of 1. Same for adverse transfusion reactions. However, the caveat here is transfusion reactions are very, very rare occurrences. So none of these studies are really powered to identify those differences. But we know when these events occur, they could be catastrophic. So then need for renal replacement therapy, again, the same thing repeats. There is no difference, no change in cardiovascular complications, and then no change in pulmonary complications. And again, we were not strict in defining what this meant. We went by what the study individually defined as a cardiac adverse event, as a respiratory adverse event, et cetera. So if you're interested in guideline process, and there's going to be a session tomorrow on how to get involved in guideline development. It's a really fun process. If you're interested, I encourage you to come tomorrow. But this is ultimately how we develop the decision. This is what we call the evidence to decision table, in which we evaluate the problem, the desirable effects, the undesirable effects, how certain is the evidence, values, et cetera. You can see all of them there. And based on that, the panel has a very robust discussion and makes the decision of what type of recommendation we're going to make. And in this case, we made a conditional recommendation against the intervention, which in this case, the intervention was to add red blood cell transfusions to usual care. And I guess the question or the elephant in the room is, what about the protocolized approaches that evaluate red blood cells as part of a bundle? Unfortunately, those studies, we could not compare red blood cell transfusions as an independent factor because those are all part of a bundle, of a package. So there was no way for us to individualize that element of the sepsis resuscitation bundle. So we decided to do our assessment on the studies that just compare usual care as the authors define it, and then transfusions 7 or 10. And then the other part that I think is very, very important, and we did this in the conclusions of the article, which should be available online, is if we do the math, the number of units of red blood cells that we would spare every year in this country, if we were to switch towards a restrictive approach, it would be 500,000 units of red blood cells. So although individually it might not seem that it's only 100 units here or there, but when we do this as a global, as a public health global perspective, we're talking about 500,000 units of red blood cells. That, if there's not going to be a change in outcomes, I think it makes sense to use a restrictive approach. Now, looking at the different population, like Dr. Ouellette mentioned earlier, patients with cardiac ischemia, that's a different population, and we should use different thresholds there. But for all the other types of critical care patients that we are assessing, there was really no difference, and sepsis was one of those in which there was no difference. And we should be really, really judicious in the use of red blood cells. Not only red blood cells, also FFPs and platelets, which there is a second part of this guideline, which is in peer review now, should be coming in the next few, hopefully, months. You never know. But at the end of the day, I think this is a really important bring awareness to this, the amount of blood products that we could save if we use a restrictive approach. And that's it. Thank you.
Thank you so much, Angel. Our last speaker will be Dr. Halvorson, who's going to talk to us about coagulopathy and medical procedures.
Good morning, everybody. Thank you for coming. It's nice to see a full audience. I will be talking about transfusion of fresh frozen plasma and platelets in critically ill adults, whether or not we should reverse coagulopathy prior to doing a said procedure. My name is Karin Halvorson. I am faculty at the University of Hawaii. I have no disclosures. So I'm going to start this talk because my talk is not one kind of question. Mine's a little broader, and I want to preface our guidelines with the complicated nuances of making these decisions prior to deciding whether or not you need to give a patient product because you're going to invade their body. So we all know that in critically ill patients, there are a milieu of things that can disturb somebody's ability to clot. So is that a problem with platelet dysfunction, meaning the patient came in on aspirin? Is that a problem because our platelets are being eaten alive because your patient has a problem with their spleen? Is that because the patient has renal insufficiency, and so just by that, their platelets don't work as well? Does the patient have hepatic disease? Does that mean that they're not making enough platelets? Does the patient come in with some sort of broad disease that's making them completely acidemic? So their platelets or coagulation cascade could be off kilter for that. Are they hypothermic? Are they hypercalcemic? Are we diluting any of their products? Are there problems with DIC? Has your patient come into the ICU because they've been bleeding from the gastroenteric tract, and so you've had to give them a massive transfusion, and just by that, you've messed up the entire coagulation cascade, and you've had to be giving a 1-to-1-to-1 ratio for the patient. So you can see that just based on this slide alone, making a guideline to tell you whether or not you're going to give a product to a patient before you put a needle in them is not going to be the simplest guideline to develop. So there are an insane number of disorders of hemostasis, as well as disorders of coagulation. And when we're talking about looking at this in your patient, a single test is not going to tell you whether or not your patient's going to have a problem if you then invade them with a needle. For example, we have been studying cirrhotics for a long time, and it does seem that a specific number of platelet greater than 56,000 is appropriate to generate thrombin in cirrhotics. If you talk to your interventional radiology colleagues who are infusing TPA into a cold leg, they're going to be very specific about their fibrinogen levels, and we do find that fibrinogen levels over 200 are associated with more effective hemostasis. But there's not just one thing here that's going to tell you it's going to be safe for you to, again, invade your patient. Other tests might be extremely helpful, such as our global viscoelastic tests, and a lot of research is going into the utilization of these, particularly in liver patients, and our transplant colleagues use this a lot in their cases. There's also a gajillion clotting factors and proteins that I'm not going to go into. So in general, when you are thinking about whether or not it's going to be safe to do a procedure on your patient, the way that we're defining these things is whether or not the procedure in and of itself is a low risk or a high risk procedure. So low risk, meaning less than 1.5% chance of having a complication, means that the complication rate is rare or the bleeding is easy to diagnose and control. So if you have somebody who has a cut on their arm, that's easy to control. If you are manipulating the spinal column, that's not necessarily easy to control. So high risk would be greater than 1.5%, expected to have bleeding, occurring in an area where bleeding is difficult to diagnose and control, or involved in areas where even a minute amount of blood could be catastrophic. So I like to make these charts for this talk in terms of what's a common ICU procedure and how does it stand in terms of this low risk or high risk. So low risk bleeding, endotracheal intubation, thoracentesis, bronchoscopy, paracentesis, arthrocentesis, central lines. What might be a little higher risk, depending especially on the patient's age and other comorbidities, might be a chest tube that actually has to sit in the patient rather than a small bore needle that's going into the chest cavity for a short period of time, an arterial line, a lumbar puncture. And you might be a little bit surprised by the end of this talk in terms of talking about our thresholds for lumbar puncture. And I'm not going to belabor all of this, but I talked about most of our common procedures. So the other thing that I would like to make note about when we're talking about reversing coagulopathy in these patients prior to doing procedures in patients in the ICU is that sometimes you can use other agents besides using FFP in particular in order to help your patient, which comes with less risk in terms of transfusion reaction or other problems with giving FFP. But you also want to be careful that you're not going to then induce a thrombotic state. But vitamin K, DDAVP, PCCs or Kcentra are all things that we can kind of consider in helping to prevent complications from procedures in our patient population in the ICU. So our guidelines are broken up into both platelet and FFP discussion. So when we're talking about vascular procedures, meaning you're about to put in a central line in a patient, in critically ill patients at increased risk of bleeding due to thrombocytopenia undergoing a central venous catheter or arterial line, we suggest against routine prophylactic platelet transfusion and against routine prophylactic FFP transfusion. Now, all of this is also to say, and if you read our guidelines, it also depends on who's doing your procedure. So what year of training are they in? And then again, also, I also personally like to take into account the patient in front of me. So I hate putting A-lines into awake humans because it's painful. So if I don't really have to do it, am I going to do it? Bedside thoracic or abdominal procedures in critically ill patients with increased risk of bleeding due to thrombocytopenia undergoing a bedside thoracentesis or paracentesis. Again, we recommend against routine prophylactic platelet transfusion and against routine prophylactic FFP transfusion. Lumbar puncture. So this is maybe a little stressful for some people in terms of our specific guidelines. And this comes from a lot of expertise, particularly at the bedside. And in critically ill patients with increased risk of bleeding due to thrombocytopenia undergoing a lumbar puncture, and not talking about actually putting a catheter in there for pain management, but we suggest a platelet transfusion threshold of 40 to 50. And this is conditional. There's not a lot of evidence for this, but we do have a lot of colleagues that are performing lumbar punctures at probably a lower threshold than many of us have been comfortable with for a really long time. So, my own hospital in the middle of nowhere, if you were to talk to all of my colleagues, 3 of us are anesthesia, 3 of us are pulmonary critical care. Not all of us would necessarily agree on this 40 to 50. And a lot of my anesthesia partners are very, very much at the 100 threshold. But I'm hoping that further discussion and guidelines are going to help us do very important procedures on patients, right? Because a lumbar puncture is being done really in emergent settings. In critically ill patients with increased risk of bleeding due to coagulopathy, we suggested FFP target of 1.5 to 2 before the procedure. For bronchoscopies in critically ill patients with increased risk of bleeding due to thrombocytopenia undergoing routine flexible bronchoscopy without biopsy, all right? So this is just going into the lungs, getting into that distal segment, doing a BAL. We suggest against routine prophylactic platelet and prophylactic FFP transfusions. And then in GI endoscopy, we also recommend against routine platelet transfusions and against routine FFP transfusions. So what are other societies saying? I think that the Society of Interventional Radiology, when we're talking about doing procedures on patients, is actually probably the best society to look at guidelines for, outside of our own guidelines, of course. But they come up with consensus guidelines for peri-procedural management of thrombotic and bleeding risk in patients every 4 years or so. Their last guidelines were in 2019. And again, everybody is dichotomizing these groups in low bleeding risk versus high bleeding risk. And so for low bleeding risk procedures, the guidelines for IR are really to not even be checking a PT, INR, or platelet count if it's a low-risk procedure, to actually go ahead and do the procedure. Now, there's a caveat to this, right, because you want to know your patient population. So if you're working in a bone marrow unit, then you may actually want to know a platelet count. Whereas if it's a high bleeding risk, then our IR colleagues do recommend checking things and making sure INR is 1.5 to 1.8 or platelets are greater than 50,000. Our liver colleagues, right? So the liver is this special beast, right? Our liver is so important for our coagulation cascade that in general, a lot of us have been looking at INRs for a long time for these patients, but INRs are not going to actually tell you what's going to happen to that patient if you stick a needle in them. And thrombocytopenia in cirrhosis is alleviated by levels of platelet adhesive protein and von Willebrand factor. The decreased levels of procoagulant proteins are counteracted by decreased levels of natural anticoagulant proteins. And their decreased levels of antifibrinolytic proteins are counteracted by decreased levels of profibrinolytics. So in the cirrhotic patient, really what all of this is saying is that their bodies are developing other things so that they're not going to bleed a lot, right? So, your average cirrhotic is not walking around bleeding all the time. Now, if your patient's critically ill and they're in the ICU with decompensated cirrhosis, then all bets are off on everything that I just said because we don't know what's actually happening to their specific system. So, but our liver colleagues, in a patient that, say, is in the ICU, not because they are, not because their cirrhosis is decompensated, but for another reason, and you do need to do a procedure on them. If they actually recommend, again, if your procedure risk is low, that you don't necessarily need to be checking all of these numbers. But if your procedure risk is high, they actually would like us to look a little bit more at our thromboelastic studies. I mentioned this earlier in the talk, but studies indicate that platelet counts over 56,000. It's very specific, which is a nice in the world of medicine to actually have a specific number, but over 56 is sufficient, and no routine pre-procedure correction for fibrinogen. The numbers from the American Society of Liver Disease are a little all over the place. Our American Society of Hematology, like what do our blood buddies think? Their threshold to transfuse FFP is if the INR is greater than 1.5 in neurosurgical patients or greater than 2 in patients undergoing any invasive procedure. One last thing on global viscoelastic tests, if you're actually going to use a TEG to guide resuscitation, if your R time is increased, then you would consider FFP. If your angle has increased, then you would consider cryo. If your maximum amplitude on your TEG is actually been diminished, then you would consider platelets or even DDAVP, again, thinking outside of the box of FFP and platelets. And then if there's fibrinolysis, then you can consider TXA. Our colleagues across the pond have not a lot of guideline. They're, the only thing I could find from the National Health System was if there's a low-risk procedure, then your INR less than 3 is fine. All right, so thank you for attending this session. Don't forget to evaluate. It's in the app. Thank you to all of this group.